Hello guys. So today we are going to talk about a very important topic, that is understanding of ABG. So this ABG has been always the talk of the town and always somewhere less understood, a lot studied, still less understood. The reason behind it is uh, there's a logic behind each and every step of ABG, and if at any point we do not follow it, and if we follow it like a mathematics, we will not be able to reach the conclusion. So we need three things for understanding the ABG and to reach at the results. One is the very important, which we always forget, that is a clinical correlation. Second is the logical reasoning behind it. And third is then applying of mathematics. There is the place where we will reach the exact diagnostic value. So So let's understand a very basics, not going into the details. What is the homeostatic response behind any of the acid-base balance? So we need three things. One is the chemical buffers, such as our H plus, bicarbonate ion, sodium potassium ions, which change the homeostatic response. Second is the ventilator settings. As soon as you put the patient on a ventilator, within an hour, the ABG findings start to change and the exact results are established in 24 hours. So ventilator settings, how there's a change in the ABG is by control of PCO2. So what happens is when we put the patient on a ventilator, what we are doing? We are changing the rate and the depth of the ventilation. Then the third one is the excretion of acid to the kidneys. So as the acid will be excreted from the body, it will lead to a alkalosis state. Second, more of the bicarbonate reabsorption. If there is a more of the bicarbonate reabsorption, again, there will be a alkalotic state. Third, there is increased production of bicarbonate in the body, again leading to an alkalotic state. Whereas in the ventilator, the change was seen within an hour. Here, the change is seen within the first day and is fully established in 3 to 5 days. So, this was just the basic of physiology behind it. Now, coming to the acid-base balance. So, how they are excreted. So, the volatile acids, such as the carbonic acid, is excreted via lungs in the form of CO2, and the fixed acids are excreted by kidneys. So, these are two different mechanisms of excretion of acids from the body. Now, this we all know. This we have been studying since our first prof rather. So, what is going to happen in the metabolic acidosis? So as the word suggests, what we are talking about is a metabolic acidosis. So what happens in the metabolic acidosis is that you are going to have, let's understand it like this. Let's read it ulta. That is, let's read it from the back. So acidosis. So okay, when the acidosis term comes to our mind, so okay, matlab pH is low. Done. Now, what does metabolic mean? So metabolic means there's something going inside it. There's something metabolism going inside. So who will do all the metabolism? So we know the metabolism is done by our kidneys. So here what will happen? There will be low bicarbonate levels. Whereas in the respiratory acidosis, we are going to have a low pH, but in return, what will happen? There will be high PCO2. That is where I was saying that in the ventilator settings, we change the PCO2. Now coming on to the compensation, how the compensation is going to occur. So if there is a metabolic acidosis, what is clear to us कि pH लो होने वाला है, bicarbonate लो होने वाला है. उसको compensate करने के लिए क्या होगा? PCO2 लो हो जाएगा. And if it is a respiratory acidosis, pH लो है, उसके उसके comparison में PCO2 will be high. So if it would have been a metabolic acidosis, so what we were suspecting that both the arrows are downwards. But in the respiratory acidosis, what is happening? There's a low pH. In return, there's high PCO2 and bicarbonate is high. So whenever we talk about a metabolic part, okay, so in the metabolic part, what is going to happen is in the metabolic part, both the arrows are going to be on the same side. So how we are going to understand it? Let's see. So if I am talking about that we have a low pH, that means we are talking about acidosis. Done. So we will be having low bicarbonate and we will be having low PCO2. But in the respiratory acidosis, what is going to happen if we have a low pH, PCO2 will be high. So if the arrows are in the same direction, if that of a pH, it is metabolic. If the arrows are not in the same direction, that means if like you have a low pH and high PCO2, that means you are talking about a respiratory acidosis. In the same way, if you have a high pH and a low PCO2, we are talking about a respiratory alkalosis. So I have some examples further that this is just a theoretical part. And even if you don't understand now, until the end of the video, the ABGs will be very clear to you. So now coming to bit of mathematical part. Again, mathematical part. So now from bicarbonate, we have to take out what is the PCO2. So what we do, we multiply bicarbonate with 1.5 and we add 8 plus minus 2. In a simplified form, bicarbonate plus 15 will give us the value of PCO2. If this PCO2 is less than 24, it is metabolic acidosis with compensatory respiratory alkalosis. And if this value is less than 28, then it is metabolic acidosis with respiratory acidosis. So this is very, very important. I used to forget it in my UG and PG days, the normal values. Most of the times, personally, I'm not good at values. So I used to forget this, but this is very, very important. The normal pH is 7.35 to 7.45. The normal PCO2 is 35 to 45. The normal PO2 is 80 to 100 mm of mercury. The normal bicarbonate is 22 to 26 millimole per liter. The base axis is calculated between -2 to +2 and SaO2 is more than 95%. These values are very, very important and usually this should be well inbuilt in your mind. Again, I am repeating the pH, the normal pH is 7.35 to 7.45. The normal PCO2 is 35 to 45. The normal PO2 is 80 to 100. The normal bicarbonate is 22 to 26 millimole per liter. The base excess -2 to +2 and SaO2 is 95%. Now, how are we going to approach to the ABG part? So first of all, we have to obtain the pH and we have to obtain the serum electrolytes. Why the serum electrolytes is important? Because you have to calculate the anion gap. So then we will check the validity, that what is the expected and what is given to us. So we will put a modified Henderson's equation and we will calculate the bicarbonate. The bicarbonate is calculated. So we will calculate the bicarbonate, that is 24 into PCO2 divided by H plus. Now the calculated bicarbonate, we have to compare it with the measured bicarbonate and this difference should not be more than 2. So from there we will get to know that our ABG is actually a valid one or not, and the bicarbonate difference should not be more than 2. Then we look at the pH and decide whether we are into which category, whether we are into metabolic alkalosis, whether we are into metabolic acidosis, respiratory acidosis, or respiratory alkalosis from this graph. Now, then we calculate the Winter's formula, that is PCO2. Simply, that is 1.5 into bicarbonate. Simply, I have told you to do bicarbonate plus 15. That will give you the value of PCO2. Then we calculate the anion gap. How the anion gap is calculated? The anion gap is calculated by adding sodium and potassium and then subtracting it from bicarbonate and chloride. So the normal anion gap is usually 8 to 12. 12 we take it as an average value. If it is either less than 8, then it is towards the low anion gap metabolic acidosis. If it is between 8 to 12, we call it a normal anion gap metabolic acidosis. If it is more than 12, we call it high anion gap metabolic acidosis. So most of the cases which you encounter in your ICUs, what you see that your ABGs and your pH is between 7.35 to 7.45. Now, how you are going to go further? If it is from 7.35 to 7.4, then it is acidosis with compensation. If it is 7.4 to 7.45, you take it as a alkalosis with compensation. So coming to the next slide. Actually, the next slide and the important slides will be covered inside it. So we have to see it very, very carefully. So in acute respiratory acidosis, plasma bicarbonate increases by 1 milliequivalent for every 10 mm rise in PCO2, PO2, PCO2. In acute respiratory alkalosis, the bicarbonate decreases by 2 milliequivalent for every 10 mm reduction in PCO2. In chronic respiratory acidosis, bicarbonate increases by 3 milliequivalent per liter for each 10 mm of rise in PCO2. And for chronic respiratory alkalosis, it reduces by 4 milliequivalent for every 10 mm reduction in PCO2. Now, what is high anion gap metabolic acidosis? What are the conditions? So you remember it like the most common, the diabetic ketoacidosis, alcohol ketoacidosis, starvation ketoacidosis, then lactic acidosis, renal failure, both acute and chronic, toxins such as ethylene glycol, methanol, salicylates, and propyl glycol. This is a mnemonic. If you can remember, that is good. But otherwise, the causes are very, very easy. That you have the lactics, you have the ketoacidosis, in the diabetes, alcohol and starvation. Then you have renal failure, and then you have some drugs such as ethylene alcohol, methanol, salicylates. So now this is a very important box which you are seeing. Uh, we always say that volume जो है that is from the water, but I will say the volume is from sodium. How? If there's a more of a sodium reabsorption, there will be more of a water reabsorption. So sodium always go hand in hand with volume status. Second, chloride is dependent on volume status. So in a simple dehydration or overhydration, sodium and chloride goes hand in hand. But if sodium is normal and chloride is normal, then think of acid-base disorder. This is a very important line which we usually forget, that when you look at the serum electrolytes, and if the sodium and chloride both are on the same, like both are increasing or both are reducing, think of a dehydration and overhydration. If, for example, sodium is normal, but chloride is abnormal, that is a very, very significant step where you need to get an immediate ABG done. The most important chief unmeasured anion is the albumin. So if the albumin will be low, anion gap will be low. So it is very important that we correct the albumin, or we subtract the part of the albumin before reaching the conclusion. So for 1 gram decrease in albumin, they add 2.5 milliequivalent to the anion gap and vice versa. So, for example, if you have a low albumin and it is, for example, it should be 3.5 and you are seeing it as a 2.5. So for every 1 gram decrease, so if the anion gap is 12, add 2.5 to it. Now you see it becomes a high anion gap metabolic acidosis. Now, this is a value how you calculate the corrected anion gap, 4.5 minus serum albumin into 2.5, or the simple way I've told that if you have a albumin of 2.5 and the normal is 3.5, so for every 1 gram, what you have to do, you have to add 2.5 to the anion gap. So delta gap, if the delta gap is less than 1, it is high anion gap metabolic acidosis and a normal anion gap metabolic acidosis. If it is between 1 to 2, it is high anion gap metabolic acidosis. If it is more than 2, it is high anion gap metabolic acidosis with metabolic alkalosis. Now, the next important thing that we need to discuss is the delta ratio, that is change in the anion gap, that is difference in the anion gap, and the difference in bicarbonate level. It is used when you have a concurrent metabolic disorders. So now the very super ultra important slide of ABG in a nutshell, which will make your diagnosis very easy. So let's see this. I hope it is clearly visible. So first of all, I have told you that you have to get a pH and you have to get a serum electrolyte. After getting these two things, now you have to validate your ABG by calculating the H plus, that is 24 into PCO2 by bicarbonate. If this calculated H plus, their values should be between two difference and not more than two. Now look at the pH. You have to categorize it into metabolic and respiratory, as whether it is acidosis or alkalosis. In the metabolic part, your pH and PCO2 will be in the same direction. And in the metabolic part, your pH and PCO2 will be in the opposite direction. Fine. Now you have to see that how much of PCO2 is decreasing with every 10 reduction in bicarbonate. From there, you will get to know that whether it is acute or it is chronic. Now you have to calculate the expected compensation from the expected PCO2. Simply, you have to add 15 to the bicarbonate value, or you can apply this formula of 1.5 into bicarbonate plus 8 plus minus 2. Then you have to calculate the anion gap, that is sodium and potassium minus bicarbonate plus fluoride. Once you see that your anion gap is high, then you have to calculate your for high anion gap metabolic acidosis, you have to calculate delta gap. How delta gap is calculated? You take the bicarbonate value and then you have to subtract it, anion gap minus 12, you will get the delta gap. Once you get the delta gap, then you have to calculate the delta ratio. How the delta ratio is calculated? That is anion gap minus 12 divided by 24 minus bicarbonate, you will get your delta ratio. Where the delta ratio is important, the concurrent metabolic acid-base disorders. Now, let's again revise it very fast. फर्स्ट एंड द फोरमोस्ट पार्ट इज कि अपनी एबीजी को वैलिडेट करो. सबसे पहले तो एबीजी लो, आर्टीरियल सैंपल से एबीजी ले लिया एंड सेकंड आपने सीरम इलेक्ट्रोलाइट्स ले लिए. आप अपने एबीजी को वैलिडेट करो फ्रॉम द H plus value, that is 24 into PCO2 divided by bicarbonate, and this difference should not be more than 2. Then look at the pH. You categorize it into acidemia or alkalemia. If it is metabolic, your pH and PCO2 will be in the same direction. If it is respiratory, your pH and PCO2 will be in the opposite direction. Then you see if it is respiratory, whether acute or chronic. Then you have to calculate the expected compensation from this formula, that is bicarbonate plus 15, or you apply this whole of the formula. Then anion gap, sodium plus potassium minus bicarbonate plus fluoride. Then for high anion gap metabolic acidosis, you have to calculate the delta gap. How that is calculated? You have to take bicarbonate and add, and you have to take the difference between the anion gap minus 12. Delta ratio, anion gap minus 12 and 24 minus bicarbonate, you will get your delta ratio. So what are the conditions for metabolic acidosis? For the high anion gap metabolic acidosis, we have already talked and we'll talk about it again. For this, the conditions are the lactic acidosis, ketoacidosis, toxin, and renal failure. So how you will approach it? You will measure the ketones and you will measure the lactic acid in the blood. So what are the conditions for the normal anion gap metabolic acidosis? For the conditions for the normal anion gap acidosis uh, are different for the hypokalemia and different for the hyperkalemia. When tendency to hyperkalemia, subsiding diabetic ketoacidosis, early uremic acidosis, early obstructive uropathy, renal tubular acidosis, and potassium stearing diuretics. And with the hypokalemia, renal tubular acidosis type 1, type 2, acetazolamide, acute diarrhea, obstruction of artificial ileal bladder, and dilution of acidosis. So for the normal anion gap metabolic acidosis, first measure your urinary anion gap, then see whether it is if it comes out to be positive, if the measured urinary anion gap comes out to be positive, it is a renal loss. If it comes out to be negative, it is a GI loss. Then you have to see the mixed acid-base disorder. We have already told this in the older slides, that for the metabolic acidosis, for every 1 mm fall in bicarbonate, there is 1 mm fall in PCO2. Okay, so this we have already studied. We are not going to go into details. And so this was about the anion acid-base disorders. So if you have any doubt, you can ask in the comment section. Thank you. If you like the video, like it, subscribe it.